seizure, syncope and sudden collapse is one of my favourite topics because the syncope patient doesn't occur, that often, but it makes up about 5% of our admissions to the ED. And when patients present with syncope, they can be a source of stress for us. And it's a very difficult thing to deal with when they come in. So today we're going to talk a little bit about, we're going to do a definition of syncope. We'll look at the differentials, some high-risk criteria. We'll answer a couple of important questions that we need to ask. We'll look at a 4-step approach that I use, and we'll look at a couple of cases, very easy cases, but they're the sort of things that tend to come into the ED. The reason why it's difficult to diagnose syncope is that it's not a condition. It's actually, it's a symptom. They come in with a symptom of syncope. And so our job in the emergency department is to either diagnose those patients or to risk stratify those patients. And in most cases, and certainly in more than 50% of cases, we're risk stratifying, okay? We're seeing who can go home and who can't, just like we do in chest pain. But this is just a little more complex because we don't have troponins and other such things that we can use. What we need to have is a good knowledge of all the causes of syncope. So they're not that difficult though. So you can have all your cardiac causes up in the top right-hand corner there. So your ischemic causes, your cardiac. So really it's anything to do with decreased perfusion to the heart or proarrhythmogenicity of the heart. Also there's a small subgroup with valvular disease where you get outflow type obstructions. They're your cardiac causes. So think about a patient that comes in with a potential cardiac cause. Your vasovagal and your situational syncope, so the person that has a noxious stimulus and passes out. I always pass out when I see blood. They're fairly easy. And if you've got a prodrome, I felt sweaty, I saw spots before my eyes, I was watching them cut the hand and then I sort of passed out. You kind of know what that is, okay? But the most important part of what you're going to do is get a good history because the history will help you work out which areas these fall into. Then there's also the situational type syncope. So, cough syncope, micturition syncope, all of that you've got to work out. There's the orthostatic hypertension in the elderly group, and then there's this other group down the bottom right-hand corner. The others. And these bloody others are the ones that really screw us over most of the time if we don't think of these things. So think of TIA, and TIA is one of the ones we're going to speak about in a minute. But think of the other causes. And I mentioned dissections yesterday. 12% of thoracic aortic dissections present with syncope as their only complaint. Okay? These patients can look well, they can be reading the paper out in the waiting room. Okay? Be careful. Think about the pulmonary embolism. We heard the case that Mohan had with a syncope patient this morning that had a PE. The subarachnoids. And you can have a headache that causes a syncopal episode. The headache's now gone. I'll talk about that when I talk about headaches later on. But you've got to think about all of these causes. So we need to have a definition. We've got to know what we're talking about. And when we think about syncope, the definition is a sudden brief loss of consciousness followed by a loss of postural tone. So they basically lose consciousness, go to ground, and then they have a spontaneous recovery. And the spontaneous recovery is right back to baseline. This is important. They have to go back to their baseline level. Now, if you're a little bit older, it takes a little bit longer for you to get to baseline level. But they all have to reach baseline. Because we're risk stratifying, we really have to understand what are the red flags, what are the things we get concerned about in the emergency department. And the only way to do that is to know what they are. And there have been some studies, there have been a lot of studies done. So this is a study in the Annals of Emergency Medicine that looked at mortality and arrhythmias. And this is Martin's study. And he basically found that there were 4 things that when they came through, they were statistically significant in predicting mortality and arrhythmias, and they were an abnormal ECG. Now, what's abnormal? Anything apart from a sinus rhythm in these studies, anything. History of ventricular arrhythmia, history of congestive cardiac failure, and age greater than 45 years. Who here is older than 45 years? I am. Who's here? Okay, so that is an independent risk factor for anything bad happening to you, greater than 40, in anything. If you're over 65 years of age, what the hell are you doing here? Go out and enjoy your life. You haven't got long to go. Right? Okay. But it's true, and you'll see that in a second. So this is another study. This is an academic emergency medicine. They looked at the risk of arrhythmia. They had a cohort and a validation study, and they found these things: an abnormal ECG, age greater than 65 years, and a history of congestive cardiac failure were statistically significant predictors. This is a Kolovicki study, and he looked at 1 year mortality, and he had some patients and he validated his study. And he found that age greater than 65 years, any sort of history of cardiovascular disease, syncope without a prodrome, And prodrome becomes really important in syncope. I'll mention the history in a second, but we might as well talk about it now. We get really concerned when somebody comes in and say, did anything happen beforehand? Did you get dizzy? Did you get sweaty? Did you know you were going to faint? I said, absolutely not. I was standing there, and then the next thing I know, the ambulance came, right? I mean, when they've got no prodrome, we're concerned about arrhythmias, all right? But one of the biggest problems that we have is we don't dig deep enough when we do the history. And you'll sometimes find a prodrome if you ask the question 5 different ways, all right? And with me, it's like the Spanish Inquisition when I'm getting this history, because it's the only way. The history is 90% of what you're going to do in this. You've got to find out. Are you sure? Did you feel sweaty at all? And sometimes I'm a bit concerned that I've convinced them to give me this history just to get me to shut up and not ask it anymore. But you've got to be... And any abnormal electrocardiogram. And we talked about this yesterday in the ECG workshops, where the electrocardiogram, if there's an abnormality in it, you're a specific group of patients at a higher risk of all bad things happening to you. Then in the Annals of Emergency Medicine, we had this study, which was the... what they put together the San Francisco Syncope rule from. And has anybody heard of the San Francisco Syncope rule? Do people use it all the time? I mean, I can't wait to use it every day, the San Francisco Syncope. It's kind of a bit of, it's not very good, really. Okay, it's like Mohan was talking about PE, it kind of smells, it smells like something bad's happening, and that's the sort of bad smell you get when you use the San Francisco Syncope rule. But what they came up with was an abnormal ECG, some shortness of breath, a systolic blood pressure less than 90, sort of for a couple of hours or so, a hematocrit that's abnormal, so if they're losing blood or whatever, congestive heart failure, and these patients, if you had these criteria, they had a 98% sensitivity for saying that something bad will happen to you. They just really, it was a 50-50 chance of them being able to tell you what the hell was going to happen to you. They couldn't tell you, you know, the specificity was so low. But they're a good set of rules. You know, if you're hypotensive with an abnormal ECG and you're short of breath, hell, I don't need a San Francisco Syncope rule to tell me something bad's going on, right? This is common sense medicine. In this particular study, they looked at 10-day and 1 year survival. Now, people pick weird, you know, San Francisco is 7 days, let's say this is 10 days, 1 year. They pick up all sorts of dates, and they had a look at what things were important. And in the table on this side here, we're seeing the factors that predict risk of adverse events at 10 days, and they were found to be an abnormal ECG, trauma as a result of the syncope. And again, no prodrome, and if you're a man, you suffer. And the one on the right, which was from day 11 to 1 year, if you're older again, if you have background bad things, you know, structural heart disease, cancer, or, you know, something bad's going to happen to you, thank you. But if we look at Quinn and Constantino together, and one is at 7 days and one is at 10 days, we'd expect similar things to be occurring. I mean, it's only 3 days difference. Right? But the recruitment criteria for the studies were a little bit different, so they came up with things that were important a little bit. An abnormal ECG is always there. An abnormal ECG is always there. An abnormal ECG is always there. You've got to know how to read your ECGs. And congestive cardiac failure comes up in a lot of these studies. Okay? Now, if they've got CCF, you're not going to send them home. But sometimes, if you've got a history of CCF, that in fact itself is a risk factor here. So you've got to get that history. The Rose trial looked at 1 month outcomes, and this is a cardiac type study, and they use beta-natriuretic peptide. Who uses beta-natriuretic peptide all the time in their ED here? I've used it once on a florid APO because I wanted to see how high I could get the BNP to come back. But I really don't use it, and I think we can clinically decipher a COPD from a heart failure. But in this particular study, when they did this, the BNP was the single most important predictor of an adverse outcome. And then they looked at, if you're bradycardic, it's bad. If you're pooping blood, it's bad. If you're anemic, it's bad. All these things are common sense, all right? But we're starting to see that the ECG is kind of important. A cardiac history of any sort is important. So these are the high-risk criteria. If you're old with a cardiac history, especially if it's a CCF history and you've got an abnormal ECG, be very afraid of these patients. And I would keep these patients in short stay overnight, okay, if somebody refused to admit them. I'd be very careful of this patient group. There are two important questions that I ask. Can TIA cause syncope? Because for you to pass out, you've got to knock out both your hemispheres or your reticular activating system. You can actually get TIA, you get syncope secondary to TIA, but posterior circulation TIAs can cause it. So vertebrobasilar deficiencies. And there was a study done, so it was a retrospective study, but it was not a bad little study, and certainly there's some others done, small numbers, but they tend to show that all of these patients will have some symptomatology. They'll have vertigo, they'll have ataxia, they'll have some symptoms that they've had a posterior circulation TIA. So you've got to hunt for it. And yes, you do have to examine the patient sometimes, okay? You've got to get in there and you've got to do it. You've got to stand them up. And, when I do the vertigo, you've got to walk them, you've got to talk them, you've got to examine the eyes, you've got to do all of these things, okay, because the clues are there. And the rapid neuro exam will talk about a couple of those things. So how important are cardiac causes? In fact, cardiac causes are so important that we can divide the causes of syncope into cardiac and non-cardiac almost, okay? TIA, posterior circulation syncope, occurs in such a small number of cases that we can say, is this cardiac or isn't it cardiac? And there's a couple of studies done that shows that, this is an extension of the, taking data out of the Framingham study that really showed the cardiac syncope doubled the risk of death from any cause. So if your cause of syncope is related to cardiac causes, not good for you. This is a Japanese study because the Japanese people have a lower risk of cardiac disease because of lifestyle and diet, etc. So they wanted to see what effect was it a cardiac-related syncope? Did that have any sort of effect? And overall, if you look down the bottom, their overall conclusion was that cardiac syncope is an independent predictor for overall mortality and cardiac mortality. Okay? So cardiac versus non-cardiac becomes very important. History, investigation, examination. I sort of ask these questions. Is it a fit or is it a faint? Is it a TIA? Is it cardiac? Or is it those other things, the PE, the dissection, the things that I'm going to miss because they're easy to miss and it's going to come back and hit me in the face? So these are the four questions. Is it a fit? Have they had a faint? If they've had a fit, they're usually not going to come back to baseline. And sort of by definition, if they're not back within 5 to 7 minutes to baseline, you've got to start thinking of this as being a fit. Okay? But the history becomes really important because if you've got an onlooker looking onto these patients when they have a syncopal episode that's a vasovagal, they can have arm movements, etc., that look like they're having a seizure to an inexperienced onlooker. You've got to be able to decipher that. You've got to ask the right questions in the history. Then we ask, is it cardiac or is it something else? I ask, what were they doing beforehand? Were they involved? And what were they doing beforehand? Is it something that's occurred that's as noxious stimulus as there's something going on and I push and I push and I push? What happened during the thing? Their arms were kind of moving like this and they were unconscious and I saw their eyes roll back. Okay. Did they bite their tongue? If they bit their tongue, is it a seizure automatically? No. Because you can bite your tongue in syncope. You just bite it in a slightly different area. I'll talk about it in a second. And if they've been going for 5 minutes or so and they're still confused, I'm a bit concerned. And you ask about family history and you ask about medications. I'm not going to show you these videos, but if you go on YouTube, you see all sorts of idiots vasovaguing themselves. You know, these guys are doing, you know, blown into their thumbs, passing out, having magnificent seizure activity, and it looks like they're having a full seizure. But they're not, okay? They're just a little bit hypoxic for a while. Most of these guys, when you see them on the net, you realise they've been hypoxic for a significant amount of time. Here's a video of it's an old video, but these guys were actually they had a vasovagal, and I want you to watch them because what happens is they start to count, and then they count in German 1, 2, so you'll hear them start to count. See how quickly that happens, and watch the movements because the movements look like seizure activity, and it's important.
Occasionally, myoclonus was generalized and symmetric.
And he starts to count, okay?
Multifocal myoclonus could manifest itself with high-frequency bursts.
So could somebody say that this was a seizure? Absolutely. The key is in how quickly do they wake up? Very quickly. Is there a remnant? Is there abnormal neurology?
Movements. This subject stretches his right arm and turns his head to the right. Grasping and head raising.
So you can have a lot of varied responses.
Sitting up during unresponsiveness.
This is a real seizure. Very different. Okay. So it's important for you when you're getting the history to find out exactly what happened to that patient. All of these things you've got to look for and you've got to ask for in terms of your examination. You make sure you do a neuro exam, and you can do a really quick neuro exam looking at posterior circulation, do a quick cardiac exam. That's all you need to do. The ECG is probably the only thing that makes a difference, and it's got a yield of less than 5%, so it's not that great. But a normal ECG indicates a lower likelihood of an arrhythmia as a cause of the syncope. So here's case 1. I showed this yesterday at the ECG workshop. 32-year-old male, IV drug user, frequent syncope, seizure activity on methadone, having these sort of seizure, kind of passing out every few seconds. No other medical history, and he gets an ECG, and the ECG should tell us the story. And if you look at this ECG, the big thing that comes out of it in the end is that he's got a prolonged QT interval. Okay, so he's got a prolonged QT interval, and then he does this while we've got the ECG. And somebody said to me, you should never capture that on an ECG, Peter. That shows bad management. I said, shut up. Because this guy actually, when he was triaged in, they said, I think he's malingering. I think he's putting it on, Pete. And I said, yeah, but, bring him in anyway. Give him the benefit of the doubt. And then he did this. Okay. So then I asked the person, do you think he's malingering now? Okay. I don't know. Okay. So QT prolongation's fine. Case 2, 39-year-old, has a syncopal episode, no prodrome, no past history, normal examination. ECG, diagnosis. Brugada syndrome. Well done. So Brugada syndrome, that slippery, slidey curve in the anterior leads. There's a couple of types of this, but this is the one that we tend to see a lot of. And when you see that sort of right bundle branch block with a slippery, slidey curve, be very concerned. That's what tends to happen to it. Okay, Brugada syndrome, it's a sodium channel abnormality, congenital defect. They got a polymorphic VT. When they stay in this polymorphic VT, it's an arrest. When the polymorphic VT stops spontaneously and they come to you in the emergency department, it's called a syncope. Yeah? So think about it. It's got a very poor prognosis when it's untreated. A significant amount of these have it again. And the treatment is really a defibrillator. A lot of people talk about putting them on beta block, and that's a different type of brigada. Okay? There's no evidence that they do anything for this type. This needs a defibrillator. Case 3, 16-year-old boy with syncope whilst playing basketball at school. There was no prodrome, wakes after a few seconds, feels fantastic in the ED, very upset that you brought him into the emergency department, wants to go home because his mum's going to be upset, and he has this ECG. And this ECG is, call it out. What? Yeah. He's got a cardiomyopathy, and the way to work out a cardiomyopathy in these, if you look at the lateral leads, he's got these kind of deepish Q waves. These very deep, sharp Q waves. And a Q wave is not an ischemic Q wave unless it's greater than 1 millimetre. So when you start getting these sorts of Q waves occurring, you start to be a bit concerned. Now, he's also got these kind of changes in here that might worry you a little bit. But that's all related to the fact that he's got hypertrophy, and you're getting T-wave changes related to his hypertrophy. 25-year-old woman with syncope. And if we use the ECG in 20 seconds approach, we'll calculate her rate. We'll look at the P waves upright in 2 up inverted in AVR, make sure there's no AV nodal issues. We look at the QRS, is it too tall, is it too small, too wide, is it too narrow? None of those things. Is it an abnormal morphology? And what we see here is we see a delta wave, right? So a delta wave gives you a shorter PR, not because it's a short PR, but because the pre-excitation allows the QRS to start earlier. So her syncope is secondary to the WPW. Whether she goes into AF or not and then spontaneously, who knows? But that's her syncope. History is the key. Yeah, who cares about this guy? I'll tell you about this one. And I can work the joke into it a little bit. Okay, this is probably the last couple of slides. 80-year-old woman, syncope in church, while standing, no chest pain, no shortness of breath, woke up quickly. Daughter says she has a fit. Okay, this is the real thing that happened. I changed this because, it's a formal conference and I can't sort of say what really happened. I'm Greek. Has anybody picked that up? I'm Greek Orthodox, and I was at a Greek church in Sydney. Stinking 36 degrees, okay? And in Greek church, what we do is we have a lot of candles, right? They're trying to light a fire in there. Massive candles everywhere. And, they have this thing about you can't have windows open in a Greek church because the Spirit of Christ will escape somewhere, they're thinking, right? So we have closed windows and a 36-degree heat with a full complement of frickin' candles, all right? But I'm very religious. I don't notice this, so I'm sitting there and I'm praying. Now, in front of me is not an 80-year-old woman, but it's actually a very, very attractive young lady, and I'm a single man at that time. I didn't have the appendage that I have at the moment. I was on my own in Sydney, and I was standing behind her there, and I was praying. I was really praying on that day. And I see her totter just a little bit, and she goes to ground. Now, if you're a doctor, unattached, in a Greek church, what you say is, it's all right, I'm a doctor. Every Greek mother goes, oh, he's a doctor. Sula kula tula vula. Come over here. Oh. So this young lady's on the ground. They've kind of, I just, roll her on the side. And as I'm about to kind of kneel next to her and lend the healing hand that I have to do the magic act, and when she wakes up within 10 or 15 seconds, But there's a bigger joker than me in the church. And this guy runs up and he goes, I have seen this before. And he puts his finger right there. And he presses right there. And this was just at about 15, 20 seconds. And just as he presses, she opens her eyes. And the church says, oh, it's a miracle, right? But then this awe-inspired group of Greek women that just a few seconds ago I was a demigod in there, I was a Greek. They turn around to me and they say, what sort of a doctor are you who doesn't know something simple like this? Kula tula shula vula, come over here, leave him alone. That's almost a true story. Most of those things happen, and the guy did do that. That's absolute reality. Greek Orthodox Church. All right. Couple of more things. 60. Okay, this is interesting. You get the case coming in with a man, 60-year-old male, who comes in following a syncopal episode while he's going to the bathroom. It's probably going to be post-micturition or defecation syncope. But get your frickin' history. What if he hasn't actually micturated yet? What if it's something else? Make sure you get your history. Man that takes 6 or 7 minutes to wake up is going to be a seizure. Now, this one is interesting. 52-year-old male brought into the emergency department following collapse. He's been sitting at the kitchen table reading the paper. Next thing he says, I knew I'm on the floor. He awakes, he's got a vice-like headache, pins and needles down his left arm, he's in AF. Are you concerned? The patient had a biopsy of his ear, okay, and they detected that he had a carcinoma. Okay, so the resident came up to me at this point and said, I'm really very concerned. I said, all right, no prodrome, nothing else? Okay, let's go back. The reality was that this guy had just had a CT looking for nodes in his neck. And he was really worried because he'd asked people what the CTs meant, what the report meant, because he couldn't understand it. And he had, they give him the bag with the report in it. And he's reading it and he's trying to understand it and he can't and he's getting stressed. And he wants to know if he's got cancer. And his brother died 3 months ago from cancer. He's sitting there at this kitchen table thinking about dying from cancer. He's getting very anxious. He gets hot and sweaty. He tells me this when I ask him. And then he collapses. Now he's sitting. Can you have a vasovagal while you're sitting? Of course you can. When he awakes, he has a vice-like headache. He has pins and needles down left, and he is in AF. He's been known to be in AF. He's been seeing a cardiologist who's only got him on aspirin. He's had a couple of episodes of syncope in the past, so he's had them before, and he has exactly the same headache, exactly the pins and needles, been fully investigated, no issues whatsoever. Now, we were busy on that day, and I ended up sending him home. But I felt confident enough on that story and the ECG normal, ECG being what we already knew he had, to do that. There's one other woman, the same shift, 62-year-old woman, went out to buy lemons, Sydney on a hot day. Within about 7 minutes, she had pain in her upper back. Fairly bad pain in her upper back. Felt dizzy, collapsed. Ambulance brings her in. She has a BP of 90 systolic. She's well looking. ECG is normal. Gets 200 ml bolus challenge fluid, and she's fine. So when the resident presented it, at that point, said, look, I'm going to do a few things. Okay, so he did a chest x-ray looking for a widened mediastinum in case she had a dissection, thinking all the right things, okay? Very worried about this collapse. So the patient went outside and she said, I felt the heat of the day hit me on a very humid day in Sydney. Now, she was actually going to buy lemons, I found out, to put into a gin and tonic that she'd been making all of that day, and she was running out of lemons. She continued to walk. She was becoming very sweaty, felt dizzy for some time, and then she panicked. She became very anxious, and it's the same sort of panic attack she'd gotten since her son was brutally stabbed to death by his partner 2 years earlier. Do you think that's an important part of the history? I think it is. Okay, you're going to need to dig. She lowered herself to the ground and she felt like she was going to pass out. She did pass out, all very briefly. The back pain was paravertebral, been there for years, and hypertension resolved very, very quickly. The only thing in that case that concerned me was that slight hypotension that was persistent. But in about 50% of cases of patients with syncope, they'll have persistent hypotension. Okay? So who to admit? 2 more slides and we're done. High-risk patients. And do we apply syncope rules? I don't. I use common sense in these patients. But that's the San Francisco, CCF, hematocrit, ECG abdomen, shortness of breath, systolic blood pressure. And then Boston have got one, ASEP have got one now, and they predict basically an abnormal ECG, an older patient group start getting very concerned. When you admit them, if you're going to put them in short stay even or in your hospital, how long do you need to monitor them for? And this is the thing that there are not enough studies out there about. And we know that 24 hours may not be enough monitoring because in some of these studies the arrhythmias occurred in greater than 24 hours. So the answer is nobody really knows how long to monitor them for. And if you're generating a syncope unit like a short stay unit, they found that the length of hospital stay in the ward was actually lower when you had a syncope unit, but the overall length of stay was the same because you just kept them in a slightly different geographical location, not on the ward, but in the syncope unit in your emergency department. Don't worry about that. Oh, the only other thing, you might find patients coming in with implantable loop recorders because they've had multiple syncopal events and people are trying to catch an arrhythmia. And these are embedded under the skin like a defibrillator or pacemaker. But some of these, the older ones, they actually have a small thing that looks like this clicker. And they have it in their pocket. And their instructions are, if you think you're going to faint, you need to take this out and put it on this. Right? And I've had multiple patients come in. I said, did you put it on? I said, no, I fainted. So, take a good history, do an examination. The ECG will give you a good clue in order to discriminate if they're old and if they've got any potential for cardiac. Admit these patients and don't forget about the sinister causes of the dissections and the pulmonary embolisms because they will sneak up on you. Thank you very much.